Hi, everybody. So just to start, I wanted to draw your attention to this beautiful quote by Leon Eisenberg. And he talks about how the distribution of health and disease reflects our social determinants. And because of this, all medicine is inescapably social medicine. So today we'll be talking to you about the evolution of our concept of healthcare, the concept of advocacy, advocacy in Canada, and how you can incorporate advocacy into your practice. So let's start by talking about the evolution of our concept of health. So we have an eye clicker question to get us warmed up. How do you define being unwell? Would you define it as physical symptoms, the subjective experience of symptoms, symptoms caused by genetic, metabolic, infectious agents or trauma, being unable to fulfill your responsibilities, or being unable to live your life to the fullest? So yeah, you have to power them on to be able to answer. Okay, so let's see what people answered. So most people say that it's being unable to live our life to the fullest. But you can see that the definitions, people will choose different answers. And that's because our concept of what it means to feel unwell actually is pretty complex. There are several words that have been used to describe this feeling. So one of them is illness. And illness is that subjective sense that you're feeling unwell. So take, for example, a patient who has HIV. He might subjectively experience flu-like symptoms. Sickness, on the other hand, incorporates social and cultural aspects of feeling unwell. So our patient with HIV might suddenly start to worry about how he'd be viewed in society. Disease is a reference to the pathological process. So that's where a lot of healthcare workers spend most of their time thinking. And disease may or may not produce symptoms. So in the case of our HIV patient, the disease would be low T cells. So this biomedical model of disease is what's dominated our thinking since the microbiological revolution of Louis Pasteur at the turn of the century. And it's a focus on pathological processes and on understanding, diagnosing, and treating the physical and biological aspects of disease. So the goal of treatment then would be to restore a patient's physiologic integrity and function. Okay, another question. How do you define the flip side? How do you define feeling well? So would you say it's the absence of physical and mental symptoms? Would you say it's the absence of symptoms that require medication or healthcare follow-up? Is it your ability to fulfill your responsibility, your ability to live life to the fullest and fulfill your dreams, or that sense of peace within yourself and in society? Let's see what you answered. Okay, so again, quite a bit of variation, but it seems the majority of you are defining it as the ability to live life to the fullest and fulfill your dreams. So actually, our definition of what it means to feel well has changed over the years. The early definition focused on the absence of disease, so really focused on that biomedical model. Health was seen as a normal state of function that was disrupted from time to time by physical symptoms. But in 1948, the World Health Organization tried to take this definition to the next level and defined health as physical, mental, and social well-being, and not merely the absence of disease and infirmity. So our definition has evolved even more over the years. And in 1984, the World Health Organization redefined health as the extent to which an individual or group is able to realize their aspirations and satisfy their needs, and to change and cope with the environment. Health is then a resource for everyday life. It's seen as a positive concept, and it emphasizes social and personal resources as well as physical capacities. And when we think about children's health, we think about their ability to grow, to develop and realize their potential and satisfy their needs. So that brings us to this concept of wellness. Wellness is a dynamic physical, mental, social, and spiritual state. It enables a person to achieve their full potential and live an enjoyable life. And this mandala by Hancock and Perkins, I think, captures that idea well. So let's take as an example a child that's growing up on a First Nations reserve. That child is made up of its physical body, but also its spirit and its mind. That's at the core. But the child also exists within their family, and the family exists within their physical environment. So, for example, on some First Nations reserves, we know that the housing is substandard, so that physical environment might be substandard. They live within their socio, psycho, and economic environment. So that includes all of the social determinants of health. They also exist within our human biology. So how is that group seen? How much healthcare expenditure is spent on that group? They exist within their personal behaviors and influence one another. So all of that exists within the human-made environment and the community, and that's couched within the biosphere, which is our natural environment, and our culture. So society's definition of health seems to have evolved. It's now evolved from the absence of physical symptoms to this holistic sense of wellness of the mind, body, and spirit. So our role as physicians should evolve accordingly. And this brings us to this concept of prevention. So prevention is broken down into primary, secondary, and tertiary. And primary prevention is really where the money's at because it's the prevention of the onset of specific diseases. And we do this through risk reduction. So we try to alter behaviors or exposures that can lead to disease and enhance resistance to the effects of exposures to a disease agent. So an example of primary prevention would be smoking cessation, public health promotion, trying to get people not to even start, or encouraging people to exercise so that obesity becomes less of a problem. So secondary prevention is this concept of trying to catch the physical symptoms early, so before the pathological process has really gone down its entire pathway. And we do this every day here in the hospital with screening, particularly with neonatal screening. That's a good example. So if we haven't prevented it from happening and we haven't caught it early, then we're left with tertiary prevention, and that's this concept of trying to minimize the consequences of having a disease. So this really tends to go with chronic conditions. So for example, a patient who has diabetes, once they already have diabetes, we would want to see them regularly and follow up to make sure that they haven't suffered from the sequelae of the disease. So Halfin said it really well when he said that our existing health measures, which tend to be tertiary prevention, have the radar set too high. We detect deviations once they've already entered the pathological range. So we need a greater emphasis on primary prevention. So that brings us to an emerging healthcare field called public health. And that's the science and art of preventing disease, prolonging life, and promoting health. And it's not just on the shoulders of healthcare workers, but also the expectation is that this promotion would be through the organized efforts of society. So it's really the science of primary prevention. And that encompasses the social determinants of health. So those are the conditions in which we're born, in which we live and work and grow. And interestingly, when they've studied it, they're starting to see that social determinants of health are important for almost every disease that they look at. So the suggestion is that there is a general mechanism where social determinants of health can contribute to a range of biological processes that affect every organ. So the science of this has been dubbed life course health development. And the landmark study in this field was done in Helsinki. It was reported in 2006, but they actually started it in the 1930s. And they followed more than 2,000 babies that were born at a hospital in Helsinki. They measured their height and weight multiple times until they were 11 years old. And then they followed them throughout adulthood and performed oral glucose tolerance tests on them. And interestingly, what they found is the babies who were born at a low birth weight had a higher risk of impaired glucose tolerance and type 2 diabetes. And if they had low weight gain in the first 2 years of their life, they were at even higher risk, suggesting that there might be critical periods for the formation of our pathways that govern how our body will respond, in this case particularly to insulin resistance. Another interesting finding was that those babies that had a low birth weight and then in the first 2 years of life gained a lot of weight, so more than one standard deviation, were also at a higher risk of impaired glucose tolerance and type 2 diabetes. So what are the social determinants as they apply to pediatric health? Well, we think about demographic and socioeconomic status. We think about child health status. So these are mortality rates, morbidity, injuries, and mental health. We think about social determinants and risk and protective factors. So in the case of pediatrics, breastfeeding is a good example of this. And then we think about child health systems and policy. So a good example of this would be our immunization schedule in Canada. So examples of social determinants as they apply to all of our health, but particularly to pediatrics. We think about poverty and education, quality of parenting and caregiving, whether or not that child was exposed to violence, whether their mother was in a good state of mind when she was raising them, the structure and organization of their home, how safe is their neighborhood, and do they have access to clean food and water. These social determinants are particularly important for children's health because they affect the child in the moment and up to adulthood, and they also influence the parents' ability to support and nurture their children's development. So imagine a family that's living below the poverty line. Those parents might have employment insecurity. They may not have money to buy nutritious food. Maybe they don't have a high enough level of education to be able to properly teach their children. And in exchange, their children perhaps are not getting the ultimate in healthcare that they could have at home and through the healthcare system. So we know that these social determinants influence these children in utero, and they influence them at birth. They influence them throughout their childhood and into their life. So here's a good study that looked at how it influences the child at the moment of birth. And what they did is, this is a cohort-based study in Quebec that was done in the 90s. And they looked at factors such as maternal education, neighborhood income, and took the information from birth registration forms. And what they found was that women in the lowest income quintile who had not completed high school were more likely to have preterm births, were more likely to have babies that were small for gestational age, and were more likely to have stillbirths. We also know from research that the effect of this is cumulative in child's health. So they did a telephone survey in the United States of over 100,000 parents of children under 17 years old. And they tested for 8 social risk factors and 4 parent-reported child health outcomes. So the risk factors were education less than high school, low family income, not having a 2-parent household, being in a minority group. So in the United States, this was defined as being Black or Hispanic, being uninsured, having family conflict, having a mother with low maternal mental health, or living in an unsafe neighborhood. And then the child health outcomes that they measured were global health status, dental health, socioeconomic health, and whether or not the children were overweight. And what they found was that parents who had more than 6 risk factors versus the parents who had none had a 17-fold increase in rating their health as fair or poor, so rating it low, and an 11-fold increase as rating their children's dentition as fair or poor. So the studies that show us that this stretches beyond childhood. In San Diego, they had a questionnaire that was answered by more than 14,000 respondents. And they asked adults to think back to their adverse childhood exposures. So these exposures included psychological, physical, or sexual abuse, included violence against their mother, or living with household members who had substance abuse problems, who were mentally ill or suicidal, or who were ever imprisoned. And they found that adults who reported more than 4 adverse childhood exposures had a 4 to 12-fold increased risk of alcoholism, depression, and suicide attempts, a 2 to 4-fold increased risk in smoking. They rated their health poor, and they had a higher risk of STDs. And they had a 1.5-fold increase in physical inactivity and obesity compared to adults that did not report more than 4 adverse childhood exposures. So these studies suggest that early life events affect the child's immediate health and also affect them into adulthood. And that it seems that marginal differences in risk exposures actually compound to create large health differences over the lifespan. So when we as healthcare workers focus on our individual patients, we can decrease this risk for an individual. But if we turn our attention to population-based interventions, we can reach a lot more people. So as Halfon said, it's clear that mounting an effective response to healthcare threats posed by social determinants will take nothing short of a transformation of our existing healthcare systems. So just to sum up what we talked about at the beginning, we've talked about our definitions of health and how they've evolved. We've talked about social determinants as a major influence in our health outcomes. And we've talked about primary prevention strategies at the individual and population levels, which are needed to address the social determinants of health. So how can we address it? We address it through advocacy. So advocacy is a bit tough to define, and we were curious about what your definition would be. Do you think that advocacy is helping patients navigate the healthcare system? Is it speaking out for the disempowered? Is it lobbying for changes in public policy? Do you consider it injury and disease prevention? Or do you have a different definition of advocacy? Okay, so variable answers, but it seems that the majority are choosing other. Okay? So it makes sense because advocacy is quite hard to define. And actually, Watterson published a review of the literature last year, and the definitions of advocacy vary quite a bit in the literature. But they tend to focus around this idea of speaking out on a cause and promoting the rights of oneself and others, which ties into the idea of giving power to the powerless. And advocacy also involves persuasive communication, targeted actions, and support for a cause or issue in an attempt to change policies, positions, and programs. So, CanMeds in 1996 decided to add health advocate to their roles that they expect physicians to play. And they define advocacy in two ways. There's this concept of agency. So that's a concept of advancing the health and well-being of our individual patients and working the system. And most of us are quite comfortable doing this because we do it day to day in our practice. But there's also this concept of activism, and that is this idea of advancing the health of communities and populations and really changing the system. This requires work with sectors outside of the healthcare sector. And here's where we tend to be uncomfortable as healthcare workers, perhaps because we're not getting enough training in how to do this in medical school and residency. So in comes social pediatrics. This is an emerging subspecialty. Currently, there's only a fellowship available in Toronto for this. And it's a global, holistic, and multidisciplinary approach to child health. It considers the health of the child within his or her social context. Advocacy is very important in pediatrics because it means unblocking injustices for a population that's vulnerable and that often can't speak for themselves. And this is not easy to do, which is why the research is now suggesting that we need specific training on how to do this. So, in case you needed further proof that we're reluctant to engage in advocacy, in 2006, Gruen et al. Polled physicians in different subspecialties. And so the good news is that pediatrics does come out ahead. But the bad news is that we come out ahead still with very small percentiles. So when they asked pediatricians to think back and see whether they had participated in their community somehow in the last 3 years, 65% said that they did. But when they asked them if they were politically involved, only 27% said that they were within the past 3 years. And when they asked them about collective advocacy, so that means joining together for issues that seem important to us in our work, only 28% responded that they were involved in the last 3 years. So the numbers are quite low. So why is this? Well, advocacy has a lot of barriers. And as we saw with the definition, one of the barriers is that it's a vague concept. It's often misunderstood. And we have a lack of clarity on how to incorporate it into our practice, perhaps because it's so misunderstood as a concept. Also, we tend to subspecialize, so our area of expertise becomes limited, and perhaps advocacy is not part of that limited area of expertise. Plus, we tend to be very busy people, and it's hard to find the time, especially since this is usually non-compensated time. Also, maybe some of us fear political fallout. And maybe we have differing agendas, so we can't get on the same page and work collectively. So should you overcome these barriers and advocate? Well, yes, you should. And Watterson argues persuasively for this. because in the literature it seems that pediatricians are viewed as lacking in self-interest. Society believes that we are experts who know the literature, and therefore we can take an objective, non-biased view of the issues. We're well informed and we understand how the system operates. Also, we're well respected by parents and society, so we have influence, and we have the ability to connect with the media. So the CPS recognizes this, and that's why they've published some targets for advocacy in their 2011 edition of Are We Doing Enough? And when you look at those targets, what really stood out to us was that child and youth poverty and early childhood development really tend to be the core. The other targets for advocacy perhaps would be minimized if we could just target families that are living below the poverty line and children that are vulnerable in that early part of their development. So as McQuain pointed out, when we let children flounder and let them fall through the cracks, we as healthcare workers end up trying to pick up the pieces in adulthood once they've reached chronic disease. And this is just unsustainable. So let's sum up what we've talked about so far. We've talked about advocacy and how it can play a role in advancing the health and well-being of patients, communities, and populations. And that despite these barriers to advocacy, we as healthcare workers are in a unique position where we can act as advocates. So Cecilia will now talk to you about advocacy in Canada.
Right, so this takes us to the next section. So now that we know what advocacy means to us, the question is, how did it originate? So in this section, I'll go through the history of advocacy and how it's evolved in Canada. So if we look back to the past at previous social structures, we can get a sense of how they influence patterns of disease. So back in the day of the hunter-gatherer societies, these bands of people would have no central leader. Therefore, they would contribute and share resources equally, thus resulting in an egalitarian society. This corresponded with disease risk, as disease risk was also distributed uniformly. Beginning with the agricultural revolution, this is when a hierarchical structure began to take place, where a leader would collect surplus resources and redistribute them amongst the wealthy. So the wealthy would often take advantage of the poor. This correlated with disease epidemiology. So the poorer people had an increased disease risk, while the wealthier people had a lower disease risk. And this, with subsequent economic transformations, this risk accelerated and made the disease risk more apparent in those who are poor. So these were the origins of the social determinants of health. Now we have another iClicker question for you, so if you guys can get those iClickers out. We just wanted to ask if you guys knew when the physician's role of advocate was first recognized. So the first option is 1800s with early Western medicine, the 1900s after the Industrial Revolution, the 1950s after the World Wars, the 1960s with the Social Revolution, and in the 2000s. So it's a completely new concept. All right. Okay, so I think that's just about everyone. All right, so everyone thought it was A. Variable answers, but the majority of people thought it was A. And you are correct, so I'm impressed. So the physician's role as advocate was first recognized by Rudolf Virchow in the 1800s. He made many different contributions to medicine, including being known as the father of modern pathology. But his contribution to social medicine was that he identified the association between poverty and disease. In 1848, he was instructed to investigate a poverty-stricken society of Upper Silesia, which was previously Prussia, and they were stricken by typhus at the time. What Virchow noticed was that there was association between people who were poor and people who had the incidence of typhus, and therefore reported that change could not just be in the form of providing medicines, food, changing food and clothing laws, but instead there needed to be radical change which involved education, prosperity, and freedom amongst the people. Dr. Abraham Jacobi was cited as the first professor of childhood disease in the United States. He was the first person who believed that pediatrics should have a specialty of its own apart from medicine. And so he established one of the first free pediatric clinics in America. So in 1923, our very own Canadian Pediatric Society was born out of the advocacy efforts of 15 pediatricians in Eastern Canada who had the common goal of advancing the knowledge, practice, and teaching of disease in infancy and childhood. Interestingly enough, the AAP wasn't formed, the American Academy of Pediatrics wasn't formed until 1930. However, despite the efforts of Virchow, it was not until 1977 that the European Society of Social Pediatrics was founded in Sweden. In 1996, the Royal College of Physicians and Surgeons of Canada made health advocate one of its 7 CanMeds roles, thus officially recognizing advocacy as one of the key competencies that we as residents and physicians must have. In 1999, the American Academy of Pediatrics put forth its policy statement on the pediatrician's role in the community. So it was then that pediatrics was described as a synthesis of clinical medicine as well as public health directed towards promoting the health of all children. Next, we have a list of some advocates who have made instrumental changes in the field of pediatrics. So these are just examples, some examples. James Spence in the 1950s pressed for parents to be allowed to stay in hospital with their children, which then eventually became the norm. In 1970, Hugh Jackson noticed the incidence of children ingesting adult medicines and therefore became a leader in injury prevention, enforcing child-proof containers. So I won't list off all the examples, but what you can see is that there's a common theme. All of these changes that these advocates fought for are practices that we now take for granted today. It's outrageous that parents wouldn't be allowed to stay in hospital for their children, but these advocates had to start somewhere, and they had to make huge strides in a system which they felt was inadequate at the time. A major advance in the field of pediatrics was when the United Nations adopted the Convention on the Rights of the Child in 1989. This convention was ratified in Canada in 1991, and so all provinces and territories are obligated to implement it. This human rights treaty forms a good blueprint for advocacy, and some of the general principles include non-discrimination, looking out for the best interests of the child, the right to life, survival, and development, and respect for the views of the child. These are some of the examples of the articles included within the convention, and we won't go through all of them, but I would like to draw your attention to some of the ones that pertain especially to healthcare. So, Article 3, the best interests of the child are always to be factored into decisions and policies. Article 6, the right to survival and development of full potential. Article 12, the right to be listened to and taken seriously. So Article 16, the right to privacy and respect for confidentiality, and Article 24, the right to the highest attainable quality of health care. Ultimately, what this convention led to was a paradigm shift. So rather than treating children as dependent on parents or their guardians for care, we now focus on a rights-based approach. What this means is that all rights are equal and universal, and that all children have their rights and should be active participants in their rights and their development. Given the fact that they are a vulnerable population, we have an obligation to make sure that all of these rights are being met. As healthcare professionals, the rights-based approach is something that we should take as paramount in our practices. It encourages us to think of children first as members of society and second as patients with medical problems. It encourages us to think of children as autonomous individuals who are independent and of their parents or guardians for care. Also, this convention encourages us to focus on primary prevention as a key target. So instead of reacting to a child's disease, to act on keeping children healthy. And of course, it makes us accountable to the children that we serve. All right, so the rights set out by the convention, the United Nations Convention, are lofty goals. And although Canada's laws largely incorporated the goals of the convention in 1991, when it ratified it in 1991, the real question is, or a better question, is whether or not we actually adopt these goals in our real-life measures. So one of these examples is in early childhood development. As you may remember from the UN Convention, some of the articles included the fact that children had the right to development of full potential and the highest quality health care. So UNICEF put out a number of benchmarks, 15 in total, which looked at early childhood programs. And for example, and some of the benchmarks that they used included access to early childhood programs. It included paid parental leave, regulated childcare services, a bunch of different other other benchmarks, and basically looked at the developed nations and saw how they did in relation to these standards. So Sweden is at the top of the list, meeting a total of 10 benchmarks, out of 15. And the other European nations, Denmark, Norway, and France, are not too far behind at 8 out of 15. The United States is low down on the list, 3 out of 15 benchmarks that it meets. So of course we have an eye clicker question for you, and we were wondering if you knew how many of these benchmarks was met in Canada. All right.
So let's see what you thought.
All right, so the majority of people thought that we did worse than Sweden and other European nations, better than the UK, because I think they only met 5 benchmarks, and better than the US, which only met 3 benchmarks. So I think you'll be surprised by this answer. The actual answer to the question, Canada only met 1 of those benchmarks. We ranked last. Now that's not a happy exclamation point that we have there, unfortunately. So if we compare ourselves to the other developed nations in other measures, we continue to fare poorly. So unfortunately, as reported by the Organization for Economic Cooperation and Development, we rank 24th out of 30 in terms of infant mortality, 20th out of 30 for child poverty, and we rank last for early childhood development and care. So let's look at the provincial level. Previously, we referred to the advocacy targets of the Canadian Pediatric Society, which are developed from the Convention on the Rights of the Child. As part of the document, Are We Doing Enough?, the provinces and territories are ranked individually on 12 different categories, on how well we're achieving the targets in the 12 different categories. And they rank them from poor to excellent. Specifically, in Alberta, we rank poor to fair in 10 out of 12 categories as outlined by that document. The Child and Youth Advocate, as we outlined here on this slide, is one of those examples. So the role of the Child and Youth Advocate is to ensure that all the rights of children are met and to ensure that they all have the ability to develop their full potential. In Alberta, we rank fair in comparison to other provinces, as our advocate reports to a minister but has limited ability to investigate the welfare of youth and children in care. So as you can see, as a country and a province, we fare poorly despite our commitment to the Convention on the Rights of the Child. It's clear that we can't just rely on governments for change, and that we as healthcare professionals working with families must be the impetus for that change. But all is not lost. So looking a little bit more in terms of the future, we already have some advocacy initiatives in Canada that address the social determinants of health. So an example of this, or a couple of examples of this, would be in Vancouver, the Richer Social Pediatrics Initiative, in Toronto, the First Duty Integrative Program, and in New Brunswick, the Early Childhood Development Centers. And basically all of these initiatives have a common theme, which is that they are a one-stop shop where families can access the resources they require. Now, these are multidisciplinary services that are offered, and what the idea is that they looked at locations that families would typically access, like daycares and schools, And they would set up multidisciplinary clinics. They would set up primary health care clinics run by nurse practitioners, as well as specialty clinics run by physicians. The families would have access to these clinics through appointment basis or walk-in basis, and they were self-referral type clinics, so anyone could access them. And what they tried to do once the families had seen the specialties and there were some recommendations by the physicians or nurse practitioners, they would then integrate these recommendations with community programs so that they could, again, put this back into the community. So what they found with these programs is that they actually empowered families to access these resources on their own. Advocacy initiatives are also present at the resident level, so I didn't want to leave our group out. In Toronto, there was a child advocacy initiative that they conducted between 2001 and 2004, where residents conducted workshops in a local school in a low-income area for parents and children. 95% of those parents reported that the workshops were useful, and a majority of them also felt like they learned something new and wanted residents to return for further workshops. So just to summarize the last section, pediatrics is a specialty that originated from the advocacy efforts of our predecessors. So the UN Convention on the Rights of the Child provides a good blueprint for how to go ahead in terms of pediatric advocacy. Canada currently does fall short when we compare ourselves to other nations in addressing social determinants, but there are newer initiatives that do present opportunities to incorporate advocacy. So now that we know what advocacy is all about and how it has evolved over time, the question is, how do we incorporate this into our everyday practice? So as you may remember from Hannah's previous section, there are many barriers to advocacy, which may make advocacy seem like a daunting task. But as with all areas in medicine, once we have an approach to it, it can make it seem much less intimidating. So the question is, where do we start? So advocacy is identified as one of our key CanMed's roles, but there's no one really telling us how to do it. It's something that I, for one, didn't learn in medical school. There's no CPS policy statement on it. And really, there's very little research out there validating different methods of advocacy. However, we can draw from the experiences of other advocates in the area. So, as emphasized by Halfin, Ernest, and Oberg in their articles on advocacy, there are 4 main objectives which can help in advocating for your patients effectively. So the first is to determine a topic area, and this may stem from a child's needs from a patient that you've seen in your practice. And to make it more relevant, you can apply it to your area of expertise. The second is to clarify the problem and its scope. So really doing a little bit of research and examining all the different dimensions of that problem to fully understand why that problem exists. Next is to develop an action plan, so a way of going about how to accomplish the targets of your problem. And this may take many different shapes and forms and may continue to evolve over time. And finally, it's important that after all your hard work on your advocacy effort, that you're able to communicate an effective message regarding your topic to the public. And this will help to raise awareness amongst the public and help to fuel them towards your cause. A pediatric advocacy toolkit was actually proposed by Oberg, and this toolkit was actually taught at the University of Minnesota in a class for healthcare professionals. So what this included was a letter to the editor, fact advocacy sheet, all of those tools that you see listed there. A letter to the editor was described basically as something where you can write about a topic and contribute your professional insights. An advocacy sheet where you list the different areas, list the different research that you've done on your topic, and list why you think that that problem needs change in that area. Political context analysis is more like an internal needs assessment. So what is the political and financial situation that might affect your problem? Building of a coalition strategy, so identifying key partners in the community who will share your voice, as well as key opponents. Developing a media strategy, an issue brief, and written testimony. All of these are potential toolkits that you use. And you may choose to use one of these, you may choose to use all of these, but I think the most important part is to know where to start. So this gives us a good place to start. And so while you incorporate advocacy into this approach to advocacy, we hope that you'd be able to educate yourself and others about social determinants of health, promote child's developmental health as the foundation for lifelong well-being, to be accountable to those you serve, and to practice a rights-based approach. Of course, advocacy can be a wide spectrum. It can include a broad range of activities and in multiple settings. It can occur in a regular practice setting, outside of hospital, clinics, wards. And we have some examples of previous advocates. So for example, Ernest related some examples in his article about physicians who acted as school board advisors. So one physician noticed that there was an increasing rate of childhood obesity amongst his school-age population, and so as a result decided linked it to poor nutrition at local schools. As a result, he became a member of the local school board and was able to advocate for a nutritional policy change. In terms of injury prevention, there was an emergency physician who noticed a high rate of injuries from children falling out of high-rise windows, and they put window guards up and noticed a dramatic decrease in the number of injuries, and they therefore was able to fuel change in the laws on injury prevention in their area. So if you're completely lost and don't know where to go, the CPS website does have an advocacy center where they provide 10 ways to advocate, as you can see, and they also provide some further tools and resources which will help you in your advocacy efforts. Now, before you go on your merry way and start up a completely fresh advocacy project, we would like to caution you towards some of the potential pitfalls. And the first is to avoid being seen as biased. So you may be very passionate and persuasive about your subject, but it's important to keep in mind that you must base your opinion on the highest quality of evidence available. Also, it helps to gather support of your colleagues. Next is to avoid becoming too political. So now is not the time to become entangled in political party politics. And finally, give yourself the best chance of success. So obviously, there's a variety of topics out there that you may want to change, but you can't change the whole world at once. So prioritize those issues that you see as most important. Pick issues that you're passionate and knowledgeable about, and pick methods that fit your personality and style. So just to summarize, you can adopt an approach to advocacy by incorporating the basic toolkit that we talked about. The spectrum of advocacy activities is broad, from writing a letter to the editor to lobbying for change, but we would like to caution you towards the potential pitfalls. So we hope that you've learned a lot about advocacy today, and advocacy specifically in Canada. And we'd like to leave you with a quote that we felt was very inspirational and would hopefully fuel you towards further advocacy efforts. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. Now we'd like to acknowledge some of the people that did help us with this presentation, including Dr. Tammy Masterson, who was instrumental in helping us with getting our slides and getting our research together, as well as Dr. Lee Ford Jones, all the way from Toronto, who helped us with our presentation. I'd like to thank everyone for coming to our talk, and I'll leave the floor leave it open.
Yes, go ahead. Oh.
You placed a lot. I enjoyed this very much, and thank you very much for presenting this, because I think it's a very topical subject. I enjoyed this very much. You defended an awful lot, and you emphasized the social determinants of health as factors involved in affecting the health of a child. Would you care to comment on the physical factors? The physical determinants of health, or the natural determinants of health, the natural environmental determinants of health.
So what do you mean by environmental determinants?
Our environment.
Okay.
So I'm assuming that that relates to sort of
Like water,
right.
Yes.
soil.
So we actually.
Yeah, so
Sorry.
social determinants and physical determinants are inextricably linked, right? So a child that lives in a neighborhood that doesn't have clean water doesn't have that physical determinant. If a child that doesn't have access to healthy food then can't grow properly. So our belief, and it seems to be supported by the literature, is that we cannot separate our social determinants of health from our physical determinants because they influence one another. So if we as a society are throwing our garbage on the ground, then our soil and water is becoming polluted, and that affects the water supply.
But in actual fact, I think most people tend not to give the environment any consideration at all. We are divorced from that.
Right.
We consider ourselves as supra from it. I'm glad to see that you have culture
Yes.
and biosphere as the basis for all of that.
Yeah, well, you can see it's the shell that encompasses it all.
Do you see a threat in the future with respect to the social and physical determinants of health?
I think that relates to why we put on this talk in the first place, is that because there are multiple threats and that we aren't addressing those threats, that it's important to take those into account and look at things that we can potentially change in our future. I think that's a key point in our talk is, we see these threats, and so we would like to change those before they become something that it's like tertiary prevention, which we're only just kind of dragging.
What do you think of the biggest threat? What do you think is the biggest threat for children?
Well, so I mean, you could take it as broad as global warming, right? If there's no breathable atmosphere, then it's not just children's health that will suffer. We will suffer as a human race. We're all interconnected.
Do pediatricians advocate for that?
No,
Probably not.
Any statement by any pediatric society anywhere that addresses that issue?
We did not come across that in our research, no.
I think it's a little out of our area of expertise.
But you raise a good point, because we are in a privileged position to start to advocate even for those broadest, biggest of issues.
Can we get some other questions?
One example where that has happened, and it's a historical example. I was born in London, and in the 50s, the houses were heated by coal.
Mm-hmm.
Yeah.
And so there was this terrible smog that enveloped the whole city. And it was the pediatricians in Great Ormond Street that lobbied very, very hard for clean coal. And then it became national policy that there would be no regular coal. You had to have the special refined coal. That was the only coal that was available. And that was what heated the houses. And the smog in London was lifted, and the children did not suffer the same chronic lung diseases. Of course, that's now been replaced by traffic. And we have exhaust fumes that create that kind of smog. And so there are times when you can completely change that physical environment and advocate.
Have other questions?
I found it interesting your suggestion that people not become politically or too politically involved. I think that's probably a bit controversial. I mean, certainly it's the government in power that decides, how much credence they're going to give to the idea that there are social determinants of health.
Right.
I think what that point speaks to is just not to become entangled in the party politics, but every party has specific objectives that they'd like to achieve, and if your ideals or what your ideals are for your specific topic go along with that, then potentially supporting that aspect of their campaign or whatever their targets are is useful to affecting change and on your specific advocacy project. I think it's more just to caution us to become emotionally involved or too professionally tied up with a party and being seen as sort of more of a representative of that party specifically.
Maybe we need more pediatricians to become MLAs.
Right.
And that's a good point, because many of the people that who are involved in making healthcare decisions are not people that have a training or background in health or medicine.
They tend to be politicians, yeah. But I think the point Halfin was trying to make when he made that suggestion is that it's important for us, if we're going to stand up and say, you know, I'm a physician and this is my unbiased opinion based on my education and experience, then it's important for society to see you as unbiased. And if you are affiliated with a particular political party, you can be affiliated in your personal life, but when you're affiliated as the pediatric advocate in your professional life, then people might think that you have ulterior motives. They may not see you as an unbiased representative of that issue.
Bob, you had a question?
Yeah. The CPS nationally is very politically involved, and they engage us in different provinces. I can remember I had 3 meetings with deputy ministers along with Maria Galvez. So they try to, their report card, they try to roll that out to the provinces in person. There are a lot of great local advocates. Tammy is an excellent advocate for foster kids. But what I find is the people that advocate well, they join with others. They join their national organizations. They join their provincial pediatric societies. I would suspect as a generality that very few people advocate well on their own.
It's important to work as a team.
So I would encourage everyone to be part of their national professional organizations.
Yes, and I agree with that. That one voice by itself is not as strong as multiple voices together, and I think, you know, that is definitely a pertinent.
And society is more likely to take your efforts seriously if you're a group of people as opposed to one individual. Yeah.
I think Lionel's been waiting to ask a question for a few minutes.
Thank you very much. It was wonderful. Just 2 points of one of clarification, one of information. The Child and Youth Advocate, as of April this year, is independent of the legislature and reports of the ministry and reports directly to the legislature now. And secondly, for those of you who don't know that bicycle helmets were not always mandatory. Pat Pierce is one of our pediatricians, was very central in working with a lot of other people to get that legislation changed in our province. So just for you.
Thank you.
Just as a comment to follow up on what was being said, is that as you mentioned earlier, wonderful talk by the way. As you mentioned earlier, you know, a physician being on the school board could make changes. So what that makes someone do is to bring different expertise to the same table, right? So we don't all have to be physicians in one board. We can be different people coming from with different backgrounds and experiences and expertise to pull it together for the same cause.
I think we're more powerful too if we work in a multidisciplinary team. Yeah. Yes.
With respect to advocacy, there was one slide where you sort of had children below the poverty line as an area you wanted to hit, as it were. Jeffrey Rose, in The Strategy of Preventive Medicine, which is a wonderful book on public health, makes the point that you're better off not to target as much as to try and aim for the whole population, because by doing so, you raise everything up. When you target a group, you're getting those maybe, but there are people in the other part that are under the same problems, and they're being missed. So, you know, in terms of programming, maybe it's better to try to look at a larger group rather than a smaller group. I know it's sexier to aim for something smaller.
Yeah.
You might be able to get funded a bit more easily, but it might not be the best public health approach.
Right.
I agree, and I think that's consistent with what the United Nations Convention set out as equal rights for all children, not a specific group or specific populations.
I also like the, you know, when you get involved with politics, remember Joe Oliver's comment about anybody who was against the pipeline was a radical environmentalist, just by definition. So it's very easy to become polarized or viewed as being polarized.
No other questions. I think I'd like to thank Hannah and Cecilia for being
Yet, I have an announcement to make, and this is the best opportunity for me, and also it ties in with the topic that you chose, which was great. So as you probably know, some of you or most of you, Dominic Lane and I are quite involved with the new school in Nepal, medical school, that was started with the specific purpose of training rural physicians so they could go out to the valleys and treat patients or prevent and do all the wonderful stuff that we talked about today. So that was actually started by David Cook. Some of you may remember David Cook. He unfortunately passed away a few years ago. So in his memory, we had started a David Cook sort of fundraiser, and some of you may have already attended the dinner that we have had. This is the 3rd year that we are doing it. So October 15th, which is a Monday, at 6 o'clock, it's at the Padmakanti restaurant, but we will get the information out. Because Susan Gilmore has the information and she will send it out. You might have already got the invite through the Faculty of Medicine. If you haven't, please contribute. $85 for the dinner, $45 will be your tax receipt. Please buy for the residents, which we have done in the past, so they can attend and see what wonderful work is being done at Nepal Medical School. And this money is raised to fund programs for the medical school, as well as to offer scholarship to the rural students who are unable to otherwise get into medicine, and also to allow for some of their faculty or some of their students to travel out to country like ours, so that they can have some money, travel money. So we're trying to sponsor a couple of people from Nepal to come to the rural medicine convention that's happening in Thunder Bay early part of October. So it's for an extremely good cause, and it ties in very well with advocacy. So please remember, and you'll get the emails out. But if you haven't got it already, please contact me and I can send the invite out. We have to let the restaurant know apparently before October 2nd, which is kind of crunch now. But please donate. Thank you.